750,000 hours reduction by using robots to automate tasks that were very repetitive.
Say that number again.
750,000 hours were saved over recent years
Unbelievable.
by using the robot.
Welcome to the HSE Talking Health and Wellbeing podcast. Today we're delving into digital transformation in the HSE and what it means for patients, healthcare professionals and the future of our services. Joining us is Damien McCallion, HSE Chief Technology and Transformation Officer and Deputy CEO. Damien's going to talk about how technology is changing the way we deliver care, the role of digital health tools and what's next on the horizon for us. So let's get started. Damien, thank you for joining me.
Not at all. Good morning, Noreen.
So first of all, I wanted to ask you a little bit about your role. For me, even saying it, technology and transformation sounds to me like a very exotic and huge job. So can you tell us a little bit about it and what your team does?
Yeah, it's a bit of a mouthful, I guess. There's a couple of pieces to it. So the first is the whole digitalisation of the health service and trying to support and accelerate that. Talk a little bit about that later in terms of the government's plan around that and implementation. So that's the whole digital team in terms of data, implementing technology solutions for patients and staff, and also then in terms of cyber and security, which, as we know in the health service, is very important. The other piece then on the transformation side is on behalf of the CEO overseeing our implementation of Sláinte Care, our transformation programme, strategic priorities, areas like emergency care, waiting list, and that's the wider service side. So those two are very interconnected. Digital can play a role in helping to transform some of those services. And lastly then, on the area of innovation, is trying to develop innovation frameworks that would allow us through Sláinte Care to support and encourage and enable innovation, but also to scale. That's probably a challenge we have all the time. So broadly speaking, the areas are connected. One supports the other. The digital should support the improvement of services through Sláinte Care. And Sláinte Care remains the national health policy.
Yeah.
It's what we still have to implement. And while some of that is policy related, it's for government around charges and so on and removal of those from the system, the public health system. Much of the balance falls to ourselves working with our colleagues in the Department of Health. So that's sort of a brief summary. And within the digital area, there's a huge range of programmes that we'll hopefully get to talk a little bit more about, and particularly with government's new Digital for Care 2030 Ireland strategy. We're trying to really accelerate the introduction of digital into our health services, as I say, for both staff, but also for patients.
Okay, and when we look at the Digital for Care framework that you're talking about, can we explain it in simple terms for the audience, people listening to us, and what difference does it really make to them on the ground?
Yeah, there's a lot of jargon around the digital side. Like in my background, while I came out of college, actually, graduated in computers years ago, but deviated away from that, worked in airlines and then worked in all sorts of jobs in the health service for many years. So I've been away from it. I guess the strength of that, I hope, is I understand the services and I know what it can actually do then in terms of the services themselves. So I guess if you looked at the government strategy, it was developed jointly between the Department of Health and the HSE. And I must say the department and ourselves really work hand in glove in this area. We've great support both ways. The department at times rightly will challenge us to try and see can we get some of these things implemented quicker. But there's a really good relationship and that's important. Every country has some form of digital strategy. How are they going to utilise digital? I mentioned aviation. Think of how that's transformed itself over, say, 30 years. When we started flying first, you had engineers in the front of the plane. In case the plane had a problem, you had maybe 4 or 6 people in the cockpit. The plane can fly themselves now. We can book a flight online. We can change our flight online. We can check in online. We don't need paper anymore. So when people talk about transformation and digital transformation and the jargon, that's just an example in another sector of how it's been used to change the complete way that the business works in that case, or the way that people, we as the public, interact. And it's made it a lot easier for us. I wouldn't necessarily compare airlines in their total or travel to healthcare. Healthcare is about people and it is about that human contact. But there's no doubt we can use digital to try and support and enable the process more. So I think if you look at the relativity of those two things, the airline on one side and how it's changed, and healthcare and probably how we've fallen behind in using some of those technologies, there's lots of really good examples, but as a system in Ireland, we have a fair bit to go. So Digital for Care sets out what's called a roadmap to 2030. There's 6 main priorities in it. One is to do things that will support patients and the public in terms of being able to access their own medical records, being able to interact around their appointments with the system and so on. Secondly, then, is putting in solutions for staff and services that make the services better. That will enable information then to be provided to staff, the electronic health record being the biggest of those. Thirdly is around innovation. So how do we look at things like artificial intelligence, encourage those innovations in the health systems that will make things better? And again, I think we might talk a little bit about that later. The fourth objective then is around the infrastructure. This is the basics that most people don't see. The PCs, the laptops, the devices, the Wi-Fi. And to give you an illustration of the challenge, only about 10% of our healthcare facilities have Wi-Fi. Now think of that relative to the public. We have a huge jump to make there and an investment of hundreds of millions. And we've kicked off a big program last year under our Chief Technology Officer, Helen Coughlin, and with the support of our estates team to really try and accelerate that now to get it into all of our facilities around the country. I was up in Buncrana yesterday, a lovely new primary care centre, and we don't have Wi-Fi. And again, the programme will address that and make sure that staff and patients, because again, many people are in our facilities, residential care, they'd value having easy access to Wi-Fi. The fifth area then is around data. So really trying to maximise the data standards so that we are able to have clear standards about information. When people see data, they know what it means, but also to use it for better planning for the health services at a population level and around services like cancer services, or even from a health and wellbeing perspective when we're looking at trends in areas like smoking. Talking to one of my colleagues in Kilkenny recently, he was talking about how there's a much higher prevalence of lung cancer in one county rather than the other, Carlow rather than Kilkenny. So again, that allows us to plan locally around smoking cessation campaigns, what sort of services we need, education perhaps for young people and so on and so forth. So that data piece is important. And lastly then is in staff and the workforce and workplace. So we've invested heavily in systems to manage our money, which is very important in relation to government, that they've confidence and the public have confidence that we're spending the money wisely. And also we've over 160,000 people working in the system. And again, we've put in big solutions with a system called SAP, which is a global system that's used by most of the big companies around the world to manage our resources in terms of people and money. So they're the 6 elements that make it up. But as I say, within that, the key areas really for the public are what can we give to us as members of the public, or patients or service users, that will help them to interact with the health service. And then for staff, we really need to do a lot more to enable staff to do their work more efficiently and effectively, and also to improve the safety. We have some really good examples of where investing in technology has led to much safer services, higher quality services, which is what our staff want to work in.
Yeah. So there's an awful lot in that, Damien. So if we do, like you say, bring it back to the patient, I know that there's projects underway at the moment. It's not like just by magic this is going to happen in 2030. You guys are working on the ground constantly to try and establish what needs to be done and what areas need to be upgraded, shall we say, like the Wi-Fi. But what difference does it actually make to a patient who's, first of all, going to their GP or going into an A&E or have an issue, have a chronic illness? Like, have you got an example of what difference it will make to them?
Yes, there's a couple of things to say there. So at the moment, the amount of interaction patients can have with us is somewhat limited. We have built up through HSE Live a lot of technology to try and have information about the patient. So when they contact us, we're actually able to perhaps do more for them. But where we want to get to in the future is, firstly, we will launch the health app in the next month. So the app is essentially a tool that will be available to the public. Initially, it will have information about where services are located. It'll have an A to Z of registered and clinically validated guidance for people. So if I'm a diabetic, it will have information in relation to diabetes, and people can trust because it's the HSE. And interestingly, when we did a survey in some of our test runs, we discovered that was one of the high values people place because they know it's the HSE versus the world of Google and all of the possible options that are there. The other piece then we focus on is maternity patients. And the reason we did that is we have an electronic health record in many of our maternity hospitals. So we're able to give information to patients. So some of the women that participate in our trial, they get their appointments and they're able to get other information, clinical information that's relevant to their pregnancy, linked and brought to them as well. So initially, it's going to focus on maternity patients in terms of providing information around their hospital appointments, which is really helpful to people. But we're going to build that out further. And we have a whole lot of apps in the HSE built over the last number of years, all independent. And we're going to bring all of those in so that all of those patients will be able to get that information consistently. It is secure, just to head that off. It's used as what's called the MyGov ID. There's about 2.5 million people in the population have registered, and people can register for that easily. And that will mean that people know when they access the app, it's secure. And we know it's them, and they know they're talking to us. It will also have all of our cards, or European Health Insurance card, or medical card, or drugs payments cards, and they'll be in the wallet in the app as well. And we plan to have 3 releases every year, so we constantly refresh what's available to the public. But ultimately, where we want to get to is that patients would have all of their meds, all of their conditions, all of their allergies, and all of their appointments on the app. And the real holy grail would be where patients are actually able to interact, cancel my appointment, I can't come tomorrow, let us know, and then we can release that appointment, but also offer patients an alternative. And to do that, we need to strengthen the investment in the systems behind the scenes that will allow that type of thing to happen. But we're not going to wait for that because that will take quite a number of years. We are going to make sure that people can get their hospital appointments on the system by the end of the year. And initially this month, we'll have all the medications that are prescribed through the GMS scheme. So that's all of the publicly prescribed. But we're going to work with GPs as well to make sure that the information around your meds, your conditions and allergies and so on are also available. And that's our target through the next 12 months to do that.
So that's fantastic. And that's a real life thing that's happening at the moment. We're not just waiting. This is the type of thing I'm trying to explain, is that it's not just all going to happen in 2030 and after that. It's actually happening now and it's live, which is fantastic. So if we go back to the patient, say, who arrives and the difference it's going to make to them when they arrive in A&E or a clinic or whatever, and all these technologies are changing, what difference is it going to make to them?
It'll depend on the service and the sector. So if you take an A&E patient, what we're trying to do there is make sure there's a full electronic health record that makes the system work better behind the scenes so that patients actually are treated quicker and sooner. So perhaps it might not be as visible, but even there, in some of our hospitals now, we're displaying the wait times. We're showing where local injury units are. Perhaps if patients feel, hang on, I actually could go there because of certain conditions, but I came to the AD. So there's small things that we can do that will help patients in terms of guiding them through from a digital perspective. Where there's other potential is if I look at the maternity area, for example, where we've rolled out an electronic record in some of our maternity hospitals and 2 more hospitals going live over the next 12 months in the Coombe and Limerick. These are the standalone maternity units who account for about 75% of all births. Because we've done that, we're able to give those patients access to their appointments. We're able to give them targeted information about their pregnancy, which means they have that in their hand. I should say as well, the app is important, but not everyone will use the app.
Absolutely.
We want to encourage use. There will be people perhaps who are disadvantaged, who may not be comfortable with technology. So it's really important we're also able to offer an alternative. And that's why we work with HSE Live through the phone line, but also people will still be able to use the traditional access through hospitals and contacting their doctor or nurse, whatever the service may be. Other areas where we see the potential for innovation is areas like wearable devices and connecting those into some of our systems. So again, patients will start to see as we start to look at more and more of those, and this gets into the area of artificial intelligence that we might come back to. So there's a lot of potential around those innovations as well.
Would an example of that be if somebody had a pacemaker and they needed to monitor the pacemaker at home? Somebody had a pacemaker for their heart, they could monitor that and they could see it in the hospital and they could record what's going on and change medications or whatever as needed. Is that what you're talking about?
Yeah, so there's various examples. So there's a lot of innovations in terms of home care. So, and the private sector is doing a lot in this area, and we're looking at what all of industry is doing. So we actually signed an agreement before Christmas with Health Tech Ireland, who are the umbrella group. And part of the reason for that is we want to try and look at how these innovations might support us in areas like you've mentioned, where if I'm at home, perhaps with respiratory illness, other chronic diseases, we're able to assess and see from a distance. And one example of that is the virtual ward, for example, where a patient comes into hospital. They don't need to stay in the hospital for that period, but they're not well enough to be discharged. They go home and they have various devices that allows us to monitor their vital signs. And effectively, a virtual ward is just that. Patients can be dotted around in their homes, up to 25 to 30 patients. They're being monitored by nurses in the same way as if they were in the physical ward. It's just a virtual monitoring.
Yeah.
That's good for patients because they're home earlier. And we know, particularly for elderly patients, the longer they stay in hospital, the more functionality or movement that they can lose. So it's really good for the patient to get home earlier. And it also allows the beds then perhaps to be used for those that are more acutely unwell. So we have 2 of those open. One in St Vincent's Hospital in Dublin, one in Limerick. Both have been working really well during the current period of pressures on emergency care in January. And we have 4 more planned this year, 1 in each of the new health regions. And we're also looking at how we can support virtual care in the community as well.
Yeah.
And we plan to put 6 more initiatives into the community also. So that's been really exciting over the last 12 months. A lot of work has gone in under the guidance of our Chief Clinical Officer, Colin Henry, to try and make sure that the clinical protocols for those patients are appropriate and safe.
Yeah.
And that's really important with all of this technology, is that the way in which we use it is safe, it's tested based on evidence and based on constant evaluation of how it's working. So that's a really good example of how we innovated around those wards, looked at what was done in other countries, and now that's going to be done, as I say, at scale, 1 in each of the health regions in 2025.
Yeah, and the whole thing of keeping people in their own houses and their recovery and everything in their family, in their own bed. It's fantastic.
Similarly, I saw an example recently, a company that we're working with in the Dublin Southeast region, and are based out of Carlow, and they're able to monitor people at home, and it's based on sensors and radars. So there's no intrusive cameras.
My goodness.
And that's able to see perhaps if someone's fallen. And when I was in their command centre where they can oversee all of those people at home, we were able to see a call come in, and it was just the person that had to take the sensor off because they're having a shower. But again, those sort of checks can be done. So you think of it where we've often heard tragically of someone falling, perhaps passing away at home with a fall, not getting treatment, they're on their own. So this allows that type of technology to be used effectively. The important point here, though, is it's best when it's supplementary. Perhaps the person will still have a home care worker, helps them shower, helps them do certain things. So it's how do we mix those together? We have to remember healthcare is about people working with people. And once the digital supports and enables our staff and enables patients, that's where really the sweet spot is, where you get the real return on these investments.
Yeah. I remember we would just have the notification that somebody would wear around their neck with the button. But I mean, things have moved on so much since then. Damien, what difference is it going to make for staff working in the areas? There's so many different aspects of it. But on a daily basis for clinicians or for healthcare professionals, what difference is it really going to make? And how are you going to get them all trained up? Is there resistance to it?
My sense when I go around the country since taking this on over the last sort of 6 or 7 months is that there's a huge groundswell for people looking to get technology to support them doing their job. The day of using paper, spreadsheets and all that should be gone. There's a certain level of technology in hospitals and very limited technology in the community. So in our Digital for Care plan, there's a couple of key things. One is we need an electronic health record, and this is a system that will support staff in every setting, and it works in hospital and community and works across regions, so that effectively patients don't know about our regional boundaries. If you live in Dublin, you may be as likely to go to Beaumont for one thing, Vincent's for the other. People in Mayo can get referred into Beaumont or to Vincent's or to the Mater. So we have to be able to support patients.
So it means then if you went from Mayo to Beaumont or the Mater, people would have your records there. They'd be able to look you up with your number and they'd be able to see what they were doing in your local hospital.
Yes, correct. And effectively, there's a number of ways we're going to do that. So one is we're rolling out the PPS as the health identifier. Communication's gone out to the system and there's a public communications campaign. And that's to make sure we can identify and make sure the person is who they say they are. And that way we can give them assurance that the information is theirs. That health identifier is really important. There's been a lot of work done on that over the last number of years, but we're really trying to accelerate that now in terms of using it and get the public to understand why we need that and why it's going to work. Because otherwise, it's very hard to connect the information together. The second is rolling out an electronic health record system. This will be the most substantial investment we'll make in healthcare in the next 10 years. You're looking at probably a total cost when you wrap in all the costs of between 2 and 3 billion euros. We've looked at Canada, Australia, New Zealand, the UK, Northern Ireland by the end of this year have had a 7-year programme running. Will have for their 2 million people a full electronic health record for the entire population.
That's a great one to keep an eye on then.
That's a huge one. And I'm leaving here this morning to go over to a session on our preliminary business case. And we're working with the department where we'll need, obviously, given the scale of investment sanctioned through government, but we're determined to move it. And we're positive to it. One, we have implemented electronic health records now. I mentioned the maternity hospitals, the National Forensic Hospital, the National Rehabilitation Hospital. So there's experience in our system of this. We also have a lot of clinical staff who've worked overseas, Canada, the States, the UK. Met one of our CAMS consultants yesterday. They're used to working with technology.
And they've seen the benefits of it.
And they can't understand why we're on paper. So we're determined to try and accelerate that project. But it's not the only project. In parallel, then, we're putting a lot of investment into diagnostics. So this year, we'll finish out the rollout of a system called NIMIS, which is the system that digitizes all of the images. What that means in practice is if a young child has an accident and a head injury in Kerry, and that needs to be read at our National Neurological Centre in Beaumont, that image can be read instantaneously and a decision made as to their care. Do they transfer to the National Centre? Now, it is rolled out through a lot of our hospitals already, and this year we'll finish the last 3 hospitals, and also private providers in primary care who we contract for public services, for GPs. So we have that full database of images. The other areas are laboratory services, which are running off very old technology, and we're rolling out a new system, went into Beaumont Hospital before Christmas, and we've seen some significant efficiencies there. There would have been a lot of staff tied up in receipt of blood samples. About 1,200 a day would come into Beaumont, big hospital, North Dublin. Now that's all electronic ordering, scanned at the point of entry, and one person is all that's needed to manage that workload. And that also brings in a whole load of barcoding in the hospital, integration into the robotic equipment in the laboratories. So it's a really modern solution. We're rolling that out in other parts of the Northeast, the Midland, and we hope to have that completely deployed in the country by 2028. And we're dovetailing it then with what's called digital pathology, which means that a sample that's taken would be digitized instead of the sample. And if you needed to get that checked, for example, for cancer, that can be read instantly and referred somewhere else for a second opinion. Or if a hospital's under pressure in terms of having the appropriate clinical staff, It allows flexibility within a region. So the diagnostic area is another area of focus, big programs. And the one other I'll just highlight today is what we call the shared care record. So the electronic health record will allow staff to view data, take decisions, make referrals, move around. It's the core system of working. The shared care record will summarise the GP data around your medications, your appointments, your conditions, your allergies, that type of information. And that'll be available to patients through the app. But also then, if, say, I'm a Sligo person working in Dublin, if something happened to me today and I landed into the Mater Hospital, God forbid tonight, they would have no information about me.
Mm-hmm.
The shared care record will mean at least they have a snapshot of key information, and that will help in my care, whether it's me turning up in a clinic or in an emergency situation. So that's also been rolled out in parallel. And that is different to the electronic health record, which, as I say, is the system that all of our staff will use in order to manage the system and provide the services that patients need.
And Damien, are we at a really low base? Have we a huge amount of work to do to get this done? Are we really far behind? If you're saying that you were at a new health centre there the other day and they don't have any Wi-Fi, is it a realistic goal, 2030?
Yeah, I think you have to be ambitious. I mean, we've had good support from the department and government. Of course, funding is always a challenge because you're competing with all the other priorities. Healthcare is full of competing priorities. I'm very optimistic about it, though. We have a strategy that's endorsed by government. 2030 is an ambitious date. But you know what? If we got 80-90% of the way there in that window, wouldn't we be in a great place? And we are at a low base. So the European Union has a ranking, and unfortunately for us at the moment, we're bottom. And you could use the sporting analogy and say when you're at the bottom, there's only one place you can go, and hopefully that's up.
Yeah.
So our ambition certainly is to really drive that up through the sort of initiatives I talked about, the electronic health record, the app for patients and service users, the shared care record that'll summarise your data, the diagnostics, and we're also investing on a transition based into community as well to get systems out into community over the next 3 years. So I'm very positive that we can still achieve a lot in that timescale in line with what's set out in that roadmap to 2030. Of course, it'll need a level of investment. Some of the figures I've mentioned are enormous. But if you look at it in relative terms and put it down per head of population, what you're investing, it's actually a very small per person. And can we really afford to still run on paper? And it's not just efficiency, it is safety.
That's what I keep thinking about. It's the safety of the patient.
Yeah, most of the things that go wrong in healthcare are at the point of handover from one professional to another, one service to another. And that's where the digital solutions can actually help. And just think of maternity services. The early evidence from the benefits, and it's still very early, the system's only been in there for a number of years, has shown significant benefits in terms of time saved for staff, clinical staff.
I have a nursing background and I keep thinking about the amount of time that you spent looking for results, looking for the chart. It's just incredible. So it means that the clinicians can spend the time with their patients doing their clinical work that they're paid to do, and they can just look it up. I mean, it's incredible to even think that that's the way it's going to be,
Yeah, and in areas like maternity as well, some of the intelligence that can be built into the system to provide prompts. So one of the initiatives we've been working on over the last year is what's called the early warning score. That can be built into the system. So that's there when nurses or doctors or whatever therapists or healthcare assistants are under pressure and it's busy. These things can be easily missed. The system can assist in prompting and guiding people around those. And that ultimately leads to better patient care. And not just if maternity, but that early warning system I mentioned was modelled up in Cavan Hospital and rolled out in the wards there in terms of the medical wards. And they've seen significant advantages for the people at the nurses' station. It automatically captures the vitals, so you're not having to go down and do that. One of the biggest returns, so in commercial business, people look at the return on investment typically it's in terms of money and staff savings and efficiencies, and that's important for us. But one of our primary benefits from these systems is patient safety. And if I take maternity as an example, where there always are safety challenges, we have the electronic health record led out by our Chief Clinical Information Officer, Richard Green, and a whole team that works with Richard in the technology office. That has been really successful. I mentioned earlier how that's now live in many of our standalone maternity units. 75% of the maternity births will be covered by early next year. We've seen the benefits already in terms of staff time released to patient care. And in some countries, they've found that tension. But the advantage you have on the other side is you're not chasing around for charts. The information you need is there to make your decisions at the point of care. And that's really important for our staff. And the feedback from our nurses, our doctors, our consultants in the maternity hospitals, they wouldn't go back. And we've seen the benefits. We've done a benefits review to see where are the benefits. There are some cash releasing savings, time releasing, but the primary benefit is improved safety. And that can also take the form, apart from just time for care, more time for people to provide care to women and their babies. It's also about areas where the system can actually prompt things like early warning scores in maternity, which are really important in terms of indicators. The technology can assist in that regard to prompt busy departments. And we've also seen that deployed. I mentioned Cavan Hospital as an area where we've deployed a solution there that allows the nurse manager at the nurses station, as the vital signs are recorded, to look at the screen and to see what's there, if there's any change, and it allows for more immediate action. Now, the design of all that's important, so it works with the flow of the ward or the flow of the unit or the flow of the emergency department, where you place the technology. And it's back to this point. It's an assistance to help staff provide better care for patients, not to replace it.
Yeah, absolutely. And that's important. But Damien, have staff and patients been involved in the development of all of these things?
Absolutely. Most of the teams that are involved in these projects are going to be clinical staff.
Yeah.
There will be certain technology companies that will have our own technology staff, our own project managers, our own business analysts, people who have experience of implementing systems. But the people you're looking for are the pharmacists, the nurses, the consultants, the healthcare assistants. They're the people who know the processes. They're the people best placed to train their colleagues and to ensure that they test the system, that it works as it was intended, and so on. So I think in each area we've been in where we've implemented solutions, I'd like to think that it's been staff-led, and certainly what I've seen so far, it is staff-led, and that's the way that we want to continue. You mentioned patients as well, Noreen. We're ensuring that there are patients on our oversight group for this whole programme and on each programme. And I think the challenge we face there, and I know it from being involved in services, is making sure that it's real engagement for people. The technology, even for our own staff at times, there can be a lot of technical jargon. It's another sort of set of language that people have to adjust to. So I think we have a responsibility to work with patients to try and make sure that their needs, and we get the best from them in terms of how they reflect within this and what they see as important. But all of our programmes will all have a minimum of 2 patients on the overall steering groups and guiding groups. And it needs to be 2. It's unfair to put one person in on their own, and that provides a support. But I think we have a bit to go in terms of when you look at things like the patient app, a lot of engagement is done with the public and patients around that in different groups. And I think we can do more there to make sure that what we provide to people is tailored to suit the way that they work, because people will often have ideas, designers and people will have certain ideas. It's a bit like when you watch the TV programmes about how you design a house, the people who are going to use it will often have a different take to Dermot Bannon. And the same thing, I think, on things like the health app, we have to make sure that patients are involved in that. And we have. Ben Cloney, who's our head of digital services, has done phenomenal work in engaging with all the various groups around that. And we'll continue to do that over the next number of years.
And that's important to say, that it's not just you develop it, that it's constantly being reviewed, the patients are still involved in the review of it, the staff are still involved in it. Hopefully the maternity staff will be able to tell the rest of the staff around the HSE the benefits of what they've learned and how it's improved their work-life balance and their workload on a daily basis. So they'll be able to tell everybody else how good it is. You know, you'd hope that they'd be able to sell it for us as well.
Yeah, and there is a lot of people who've used it overseas, but equally we have to be upfront and say, look, implementing a solution in a service is a big change. And there'll be a huge hump in terms of that workload for a period in busy services. Most of our services are well stretched. So it's really important at the same time we get the right people out, we get the best people out to lead these programs. And we accept there'll be a speed bump. It's very rare you'll go in afterwards that it's working really well. There's always issues that you got to tidy up and make sure that's there.
Yeah.
And like anything in life, there'll be a proportion of people who are right at the edge, a proportion in the middle, and perhaps a proportion who are less reluctant. And we've got to make sure whatever we do, that we cover all of those types of people, whether it's staff or partners. So I think there is a lot of work involved in this, but I'm seeing a lot of excitement from people. The question people want to know is, when will I see it? How do I get involved? So that's really encouraging. And I think hopefully we will be able to support them by getting these programs running and rolled out. Some of these will take years.
Yeah.
You know, they're big programs and they will take time, but we're trying to accelerate, as I mentioned earlier, a lot of the basics, the Wi-Fi, the patient app, the shared care record. Those will all have deliverables this year in 2025, while we equally have to go, you know, with something like the business case and procurement for the electronic health record will certainly take somewhere between 1 and 2 years if we get a tailwind to get all of that to the point then we're commencing implementation. So we're not waiting for the big pieces, we're moving other things along at the same time.
And Damien, what do you say to people, because we've mentioned the Gov ID and we've mentioned another identification number, what do you say about the skeptics who say, oh, it's like Big Brother, they just want to get all my details? I understand the benefits of it, but some people will be a little bit skeptical about the whole thing.
Yeah, and that's not a bad thing that we're challenged around that. I mean, safety is important, but equally for us, what's really important at the moment, how do we know I am who I say I am when I land in if I just go with a name and a phone number? So, you know, all of the things we're talking about are there ultimately to protect the public, number one, but also to assist the system to connect the pieces together so that the person, whatever the service is, a mental health service, a disability service, a hospital, that we're able to join up the information for people, because that's going to mean that they get a safer service. So I think that while that skepticism is healthy and we have to be able to address it, we have obligations, for example, under the data protection legislation. So we're very conscious of those. And in the HSE, the data protection doesn't sit with me deliberately. So that can provide a challenge into all of these systems and solutions. And the PPS is really important for us because we need a system, a number that we can know that, Damien McCallion is Damien McCallion, and that wherever we go in the system, we're able to pull that information together. So like my example earlier, if I happen to keel over and end up in one of the Dublin hospitals, people will know and be able to go in and search and find that and connect the information together. That ultimately could make a big difference to me in terms of my life.
So, Damien, there's a huge amount of work going on and there's a huge amount of work to be done, but we're constantly hearing about AI at the moment. And I'm nearly afraid to ask you about AI because constantly people say about the risks about AI or the dangers associated. Now, I can see huge benefits in the healthcare environment for AI. So what are your thoughts on that one?
There's a couple of things. From a safety perspective first, one is there's an EU AI Act that was enacted in February. And over the next number of years, different parts of that will come in. So that will also provide a level of protection, particularly in sensitive areas like healthcare for people in terms of guardrails to guide us through it. What we've done here in Ireland is with the Department of Health, we've made a referral to HICWA, and HICWA have commenced a piece of work to look at an ethical framework for how we could apply AI in the health system. So that's really important. But in parallel as well, AI is actually coming in all of the time. So what we're doing then is we've stood up an AI Centre of Excellence, an automation Centre of Excellence in the HSE under a guy called Kevin Kelly. And Kevin had previously done a lot of work in what's called robotics and automation. His team had delivered over the last couple of years about 750,000 hours reduction by using robots to automate tasks that were very repetitive.
Say that number again.
750,000 hours were saved over recent years.
Unbelievable.
By using the robots.
Yeah.
And one of the interesting ones is a robot called Ruin. They give them all a name.
Yeah.
In Galway Hospital is where it started. It's now been rolled out to all hospitals. And it does an administrative process, basically checking the waiting list every day with the National Treatment Purchase Fund to remove people who were duplicates and matching and so on. So there's a whole process. And the robot works away happily overnight, does that work. And that releases the staff then to do other work.
It's not an actual robot as you imagine you see on the telly. It's a robot within the computer that's looking at the systems and the data.
Exactly, yeah.
Okay.
So we all think of those of us that are old enough to remember R2-D2 in Star Wars.
There's not a robot walking around at night in the hospital looking at
this particular robot. We do have those robots as well in pharmacy, actually, in one of our hospitals.
Yeah.
And there's pilots there. But this robot is a robot, you're right. That's a virtual one in the background that works away and does as if someone was sitting there just doing all of that work. Going back to AI, we have real examples. So the Mater, one of our consultants there, has done some really good work around identification of fractures. So there's a rate around fractures where up to 20% can be missed in emergency departments. People are coming in late at night, multiple fractures. We often probably all know our kids at some stage had a fracture, go back 2 years later. Someone says, oh, there was another fracture there, a hairline fracture perhaps, or whatever was missed.
And it's just important to say that this happens. This just happens.
Exactly. It's part of care. It's part of accepted. The norms are there and there's research that shows these sort of numbers are there. If you imagine a busy emergency department, small hairline fractures and so on, all of these things can get picked up. But the AI has been used to try and support that and reduce that and bring that down. So it's actually finding them most importantly at the point of care and allows the clinician to make a decision. Does it agree with what the artificial intelligence is telling it or not? So there are pockets of examples. We've lots of those at the moment. There's a tender we've put out before Christmas around stroke in terms of identification of stroke. And again, we know there's software there, artificial intelligence that will support that. And we also have pilots running around emergency care. So looking at our hospital data, our population data, looking at GP data, our primary care data, probably more specifically, to try and see, can we identify people potentially who are most at risk of coming into hospital and actually intervene almost before that arises.
Yeah.
So some of that will be local intelligence in some services. But I suppose as our population becomes more diverse and in terms of the different nationalities and countries and so on and the scale of our towns and cities, those type of tools and data are becoming more and more important, where perhaps 20 years ago, someone in the hospital would have known that Mr. McCallion is 85 there, he's a risk. Now that same awareness, perhaps to the same level, it may not be there. So AI can play a part in that. And we have a proof of concept going on in one of our regions to try and see, can we identify those people, get them connected into our new program for older people And that will hopefully prevent them having to go to hospitals.
We have the regions now, so a lot of this stuff will be localised, and there's coordination between the hospital and the community, and it's all flowing into one region for the community living in that region.
Yeah, and as you said, Noreen, then each region will be slightly different, and the criteria and the data perhaps as well. And we know, for example, disadvantaged areas may also be areas where, in fact, the health needs are greater. So again, all of that information is really important in terms of how AI works in that example. But also we've seen, and I had the privilege to attend what's called the AIM Summit this year, American Ireland Medical Summit, and that looked at AI this year as a topic. And some of the stuff that has been done between ourselves here and the US, and again, their conference is on this year in Chicago, I think, and those sort of innovations are really helping to look at internationally what's happening and how can some of those be brought back to Ireland. So on the legal side, ethically, we're making sure with HICWA, whatever we do is safe. We've stood up a framework group in the HSE to make sure that we meet our compliance under the Act. We have a register of all the AI initiatives that we have, so it can't just kick off willy-nilly. And then, as I say, we're supporting real examples on the ground where we can, either through funding or through awareness. And then we have this Centre of Excellence who will try and work to support areas. And I mentioned radiology earlier. Our aim this year is to have a small team that will work in radiology to look at where are the examples where it could actually assist. And that word assist is really important. It's about supporting
it's not taking over.
and enabling. Yeah. Exactly. I mean, there may be areas like automation that I mentioned where it allows us to release staff of those repetitive tasks. But in healthcare, certainly, where we're focused at this stage is really on that piece around removing repetitive tasks, automating those sort of things that we should and could automate to release staff to other tasks. But also then where we can improve the quality of care through some of the examples that I gave.
And I think one of the examples that you said, that if it identifies a hairline fracture, that the consultant can decide if they agree with it or not. So it's not that the AI is leading out in it, the clinician is still leading out on this and is involved in the development and all the rest of it.
And the evidence base is important because effectively most AI works on the basis of what they call language models. So it builds up the intelligence. And the more it does, the smarter it gets. I suppose a bit like ourselves, hopefully, as well. And that's how AI works. And there's different types in terms of what they call generative AI, which is that piece. Because you have to remember, artificial intelligence has been here since the 40s. Machines have had logic built into them in all sorts of sectors over the years in terms of making determinations based on data and based on what it's taking back. The difference with the generative AI, I guess, is that it's learning as it goes and the model is getting smarter. But one of the talks I was at recently in radiology, where they'd used a lot of the younger staff around that. The problem then is it's learning from the younger, less experienced staff. So the outcomes weren't as positive. So they actually had to change the model where the more experienced staff actually used that initially so that the model got more intelligence. That's just a small practical example of how you've got to think all these things through. But I think we're making sure the ethical piece is right. We're making sure we support the system to enable us to use it because we don't want to get caught either where we're behind the curve. We're certainly looking to see how can we use it to improve healthcare in terms of outcomes. And I mentioned then the robotics as well on the efficiency side, where we really are aggressively going after that to see can we eliminate a lot of the repetitive tasks to release our staff to do, the higher value and better use of their own time as well.
And Damien, I have to say now, it's mind-boggling, the job that you've taken on, but it just is absolutely fascinating. I think your enthusiasm and commitment to it is brilliant. What would you see is the biggest challenge? I mean, there's a lot of challenges there, but what would be the biggest challenge that you have ahead of you?
Yeah, first of all, I think it's a collective effort. So there's a huge team in the technology and transformation directorate that are focused on all those programs I'm talking about. So while I'm sitting here talking to you, they're off running those programs and implementing those. So that's really important. It's also in partnership, as I said, with people in the services at clinical level and service level and all categories of staff. So all of the teams are multidisciplinary as they need to be to implement those. So I think that's really important. This is about a system-wide effort. We're working with the professional bodies, we're working with patient advocacy groups, we're working with industry. So it's the collective effort that will ultimately give us the type of returns that we hope to make. So that's a really important point. I think in terms of the key things for me, some of the challenges and the opportunities around it, if you want to turn it both ways, it's really about making sure we get the leadership, get the people who can actually make a difference. So most of the companies that we work with in the main have implemented these solutions in other countries. The challenge for us is making sure we identify best practice. Most systems, while they'll allow a certain amount of local customization, by and large, we need to agree what's the best pathway for cardiology, for mental health. And then we've got to implement that. And that means everyone committing to a best practice and a standard way of working. And that involves change. And that's the bit, I think, if we get that right, I've no doubt we'll get the return on this. And that's about getting people engaged and involved and the right leadership then to drive those out clinically, operationally. We have this phrase now that we've come up with on it, which is patient-centered, clinically led, service-driven, and digitally enabled. So it's a bit of a mouthful.
That's great, though. It incorporates all
The four elements, really,
Yeah.
and that each person has a role in that. And I think that's what will make it successful. We've talked to Alberta in Canada, done some brilliant work, 5 million people, same size as Ireland, 4 regions versus our 6. They've just finished their full electronic health record. Northern Ireland, 7 years, fantastic job done up there. When you're in it, you probably don't see it, but when we look in and meet our colleagues up there, like they've done a super job up there. So you can see the potential, but they're the ingredients. They've had all of the key clinical people involved, really good support operationally and from their department, good digital solutions picked, so they've picked the right products that work for them as well. And they have the sort of teams and make it happen. So I think that's the magic sauce, for want of a better word, in this, is to get that team together that can actually make sure these solutions work.
And you've seen it work and you've seen the benefits in all these different areas. So it's fantastic. We probably need to finish up now, but if you could tell the public one thing about the future of digital healthcare in Ireland, what would it be? Maybe it's too much to ask you just for one thing, but what would be the main thing that's going to make a difference to them?
I think for me, ultimately, what all of these programs will do will make healthcare safer. It will support our staff, most importantly, to make it safer. But also I think we'll put more power into the hands of the public. The public are doing that anyway. They're going into their AI tools, their ChatGPT, and typing in, I've got these symptoms. They're going to Google Doctor. They're getting all of that anyway. So what we want to do is give them a trusted source that's reliable, allow them to interact with us, but also not forget those that are marginalised, perhaps, or disadvantaged, who may not want to engage in that way, so that we always keep an eye on those groups as well. So I think ultimately, if I was to sum it up, it is about trying to give patients the tools that will allow them to work better with the public health system, take more control of their own health as well. People are doing that anyway. If you talk to a GP now, they'll say one of the challenges is, we all come in with all sorts of ideas already from our symptoms. We've Googled it, and they have to manage us back. That's a completely different practice to where it was 20, 30 years ago. So I think the potential that's there for us as the public health provider to give reliable information to people, to allow them to interact with us, I think that would be the most powerful thing that we could do. But to do that, all of those other pieces I mentioned have to be done over the next couple of years, up to 2030, to allow that to happen successfully.
So that brings us to the end of today's episode. There's an awful lot in that. I'd like to give a big thank you to Damien McCallion for sharing his insights on digital health and transformation in the HSE.
Thank you, Noreen.
As we've heard, technology is already making a real difference in how care is delivered, and there's so much more to come. If you want to learn more, please have a look at hse.ie and have a look at the Digital Care Framework 2024 to 2030. As always, if you found this episode interesting, please share with friends, family or colleagues. Thanks for listening.